Welcome to Research Perch from the Massage Therapy Foundation. Short, practical insights into massage therapy research and how it can benefit your practice.
Hey everyone, welcome to Research Perch. I am Annie LaCroix. I am the Associate Director of Massage Therapy Foundation, and I am here with two people that have been on Research Perch many times, Ruth Werner and Dr. Niki Munk. Thank you both for being here. All right, let's do some quick introductions. Ruth, past president of MTF, and also the author of A Massage Therapist's Guide to Pathology, and additionally, a faculty member at several different places with her asynchronous online course for pathology. Yes, welcome. Thank you for being here. And Dr. Niki Munk, you are the chair and associate professor of health sciences at Indiana University. I'm going to get it out. And also, you are the research director of Massage Therapy Foundation. So thank you for, and you've been on the board of the foundation for a long time prior to being research director. So thank you so much for being here. And I will let you two take it away with today's topic. Niki.
Thank you. Well, we are so excited to be here because it's like, I know it's not a Tuesday that we're recording this, but I feel like it's Throwback Thursday or Throwback Tuesday or whatever, because we used to do Research Perch way back in 2014 when this thing started, and we're doing a little bit of a retro, and we're revisiting some of our former roots, which was very much grounded in the International Journal of Therapeutic Massage and Bodywork, or IJTMB, and also within our love and appreciation for case reports. Of course, I was one of the authors for the TMB Adapted Care Guidelines, which are the case reporting guidelines.
Hey, Niki, what does TMB stand for?
Therapeutic Massage and Bodywork.
Oh, thank you for clarifying that.
Yes, indeed. And we're going to be taking a look at 3 case reports today, actually, that came out of the first ever special issue of IJTMB that was focused on mental health, that came out back in September of 2025. And just pleased as punch that to see, after a little over a decade now that those case reporting guidelines came out, the quality of reporting of these case reports are just really fantastic, and also all couched within the theme of mental health, and particularly with trauma and PTSD. So also in reflection of our old school approach of sort of journal clubbing, one of the things that we used to do, Ruth, was you would take away and talk about the pathology aspects, couched within your expertise, and then we broke down the learning points around the case reports that can be applied to practice. So why don't you go ahead and take it away and give a little bit of a overview of our 3 cases.
Awesome. Thanks, Dr. Munk. Dr. Francie Pants Munk.
That's right. Francie Pants.
Good. I'm happy to do that. The 3 reports that we are looking at today all address the intersection between welcomed touch, which is another way to talk about massage therapy, and forms of PTSD, which of course stands for post-traumatic stress disorder. PTSD, depending on who you read, okay, NIH and the DSM, the diagnostics, I always have to look it up, the DSM-5, list these a little bit differently. The DSM-5, which appears to be the resource that our authors went with for these reports, lists PTSD and associated disorders separately from anxiety disorders. And that's partly because it responds better to some different treatment strategies as compared to other anxiety disorders like generalized anxiety disorder or social anxiety disorder or some others, right? So they made a new heading called Trauma and Stressor Related Disorders. PTSD is sort of the anchor of that heading of the trauma and stressor related disorders. And typically what we find there is a history of some kind of traumatic event, or, a single event, or a lived history. For instance, someone who grows up in a house with domestic violence, or someone who has, stacks and stacks and stacks of adverse childhood events. And those can reflect a little bit differently, but the principles are the same, which is that our central nervous system develops coping mechanisms. And the coping mechanisms clearly work, right? Because the person is still with us. However, they can lead to some changes in habits, some changes in behaviors and responses and expectations. And that is often a reflection of actual neuroplastic changes in the brain. So is it okay if I talk a little bit about the limbic system and the HPA axis? Please, please, can I?
Absolutely.
Please?
Yes, please.
Okay. I have a new desk chair and it lets bounce. It's very exciting. Right. So the main structures in the brain that help us to identify and deal with stress are the hippocampus, the amygdala, parts of the prefrontal cortex, and their connection to the hypothalamus. So you all might remember that the hypothalamus is this little glob of tissue in the center of the center of the center of the brain. It is so nondescript, it doesn't even have a name. They named it, oh yeah, that thing that's below the thalamus, right? The hypothalamus. But while it's in there, it is basically running our chemical state through control of the endocrine system, and our electrical state through control of the autonomic nervous system. The hypothalamus is informed by information coming in from the amygdala, the hippocampus, and the prefrontal cortex, which is sometimes referred to as the limbic system. So what's happening all the time probably for every organism, but certainly for every human, is that especially while we are awake, we are constantly scanning our environment to decide if we're safe. And if we have a personal history where this kind of setting, I'm sitting here at my desk and I have a screen behind me and my little dog is snoring on my foot, and I have my little life set up in such a way that I know what's going to happen next, I can feel pretty safe. But if someone listening to this, for instance, is in a situation where they are not sure that they are safe, all of those mechanisms in the brain around the hypothalamus and the amygdala and the hippocampus are going to be behaving a little bit differently. People who people who have come through the kind of traumatic events that get this going, and the severity of that event is highly, highly personalized, right? Find it much harder to feel safe. Their sense of hyper alertness is constantly on because of the risk that they feel, completely legitimately, regardless of their current settings, that they may be under threat. This can seriously interfere with quality of life. This can lead to not just to changes in sort of mood, but in changes certainly in behavior and self-regulation, in physical health as well as mental health, in relationships, and ultimately, in addition, of course, to things like cardiovascular disease or risk of diabetes or sleep problems or, any of these other kinds of things. What interests me particularly about PTSD is that those plastic changes in the brain, the changes in the size and function of the hippocampus and the amygdala, which are basically the places where we store memories and interpret them for safety. Those changes can become permanent. That can be, if they get to the point where they really have changed, they don't reverse. And so while a person may be able, logically to say, this is an unrealistic fear, all of their fear responses are still going to be in them. And it takes a lot of courage to try on the possibility that maybe things could be different. And I don't want to get doomy and gloomy right off the bat here, but there are some really specifically difficult challenges to overcome, especially for people who have lived with this for a long time. I want to add a couple of things about PTSD. One is there's a version of PTSD that actually doesn't come up in our series today. We could almost call these a case series, couldn't we? There's a version of PTSD that doesn't show up in at least in what's written here, although I suspect it was present for at least one of these clients, and that's called complex PTSD. And that's a situation where, as opposed to sort of the more garden variety PTSD, where there's an event that crumbles someone. With complex PTSD, there's a series of them, often beginning in childhood. And so this is something that we would see with someone who grows up in a home with domestic violence, or who has lived in a war zone, or who, has had these terrifying, scary, threatening things over a prolonged period of time. That leads to some different kinds of reactions. The other sort of variation on PTSD that does appear in our discussions today is the symptom of dissociation. So PTSD has some relatively predictable symptoms around re-experiencing things and having flashbacks and having nightmares and having symptoms of wanting to withdraw and not be with people and lashing out and poor self-regulation. And for some people who have PTSD, they have this sense of dissociation. And one of our papers today taught me a lot about dissociation, because I don't have a huge amount of experience with this personally. So dissociation is a state where someone simply checks out. It is too scary. It is too threatening to be in this moment. And so it's almost like an absence seizure. They are present physically, but mentally they are gone. And this can sometimes be dangerous, and very, very concerning, and involves some really different processes in the brain, because with dissociation, people are becoming hypo alert rather than hyper alert. Which is just it's a mystery to me. I don't really understand it. But what we find is that for people who dissociate with their PTSD, it can make that disorder much, much, much harder to treat, because they have a coping mechanism. It's not a great coping mechanism, but it's the one that they can revert to because it works for them. Right. So there's a couple of things I want to really emphasize about this. One is it's sort of easy to as we try to learn about this, to say this is a dysfunctional reaction to a stressor. And I want to fight back against that, because it's a highly functional reaction to a stressor that outlives its functionality. Right. And the other thing that I want to add about PTSD, and I'm curious that it did not turn up in our papers today, is that one of the things that makes it different from other sorts of what we might call anxiety disorders is that traditionally the treatment for PTSD has been working, in addition to dealing with dissociation or dealing with other kinds of, recognizing patterns, has been doing that in community. So the literature on successful PTSD treatment often deals with group therapy and family therapy, as people support each other as they walk this very, very difficult path. And that we don't see that with all of the other kinds of anxiety, which is why, one reason DSM has sort of separated it out. Yeah, so let's stop there. And I hear doves. Someone has doves in their background. How pretty. No? Maybe it was me. Sorry. We can.
I know that might be outside your window, Ruth Werner.
I guess it is. Yeah. Kurt just said we have doves. All right. Sorry. You can edit that. So,
That was an excellent like grounding because as you say, all three of our case reports today are variations on these themes. So I'll do a real quick rundown of the three cases real quick. I'm going to, I guess the logical way to do it would be in order that they are published in this particular issue, but I have it organized a little bit differently
go for
because
it.
of my little gerontology mind. I have them progressing by age.
Mhm.
So we have one case that comes to us from Arizona, a collab from Arizona and actually Sydney, University of Western Sydney, down in the Melbourne area with Sarah Fogarty as the supporting author, but the primary author is Anna Hanas, I believe is how you say that. And she wrote this case report while she was a student when this case report occurred, when the treatments actually occurred. And this is a case where it is let's see, a domestic abuse history, which you had mentioned is one of the places that this shows up, 25-year-old female. And then our second case report comes to us from British Columbia, and Alison Fraser is the primary and only author. She also was a student when this case occurred. Um, and she is working with a post-traumatic stress disorder, working with a 35-year-old Indigenous female who was in relative good health. However, she was a survivor of the Canadian residential school system.
Her
And
family was. Her family was.
thank you. Yes, yes, it wasn't just her. Yes.
Right. So there we're talking about epigenetics along with everything else.
Right. There we
Yeah.
go. And one of the things that was really interesting about this case as well, in addition to that background, while she was going through the series of treatments that she was working with in this case study, there was a discovery of a new burial site, which just brought additional trauma and those pieces.
It's
Um,
it's what we might call that a confounding variable.
Yes. But again, the complex, right? The
Right.
complex,
Complex PTSD. Yeah.
right. And then the final case report comes to us out of the Ohio State University in Columbus, Ohio, with Melissa Clark as the clinical and first author on this, and one of the primary therapists. I say one of because there were actually two massage therapists that engaged with this particular case report. We'll talk a little bit more about that here in just a little bit. And then Dr. Beth Steinberg was the senior author, and I am totally making an assumption here, but I think perhaps is one of the primary care providers also of this particular case, because this is one that really highlighted the massage therapist as part of the medical team, and also the massage therapist had access to medical records and things like this. And this particular case was of a 44-year-old woman with severe medical trauma. She had a chronic or has a chronic degenerative illness with very limited treatment options. And so a lot of symptoms that went along with that. And I'll go ahead and
Multiple surgeries and
yes, yes. And in fact, even during the series of treatments that she received during this case, had a couple of surgeries and then a substantial illness following a surgery that was recovering from that. And this
what was a curious thing about this one, I've never seen this in a case report before, is it covered 2 years worth of
yes,
working together. Usually we see that with the student case reports, it's 6 to 10 weeks. This
right.
one went for 2 years.
It did, right. So there was 27 total sessions that went from 2022 all the way through 2024. And it started off with because of the health concerns and health condition, they started slowly at first and pretty sporadically, but then once year 2 started in March of 2024, started coming regularly every month. And then in the last 6 months, ended up adding a second therapist who doesn't appear to be an author, because it was a male therapist, and was actually also credited with helping to progress the improvements in their comfort around and limiting their touch aversion, credited because so many of the people who she'd had the medical procedures from were male.
Right.
So just sort of that piece that went along.
If I can just interject here,
yes,
Niki, this is what I love about case reports that you can't do in something like a clinical trial, right? Because case reports are personal. They are interactions they are one-on-one interactions. And so to make an adjustment or to make an accommodation for the fact that in the middle of this case report massage series, there's a big event like the discovery of another graveyard, right? Or the woman, the person in the final case report who wanted more and more massage, and they recruited, and she decided it would be good to have a male because that's what she's really facing up against, right? Is touch aversion because of the way she's been handled rather than touched in her medical history. And the case reports are so human and they are so accessible, and they're great ways to understand what makes massage therapy unique.
Yes. And I want to add a little bit of you can have these sorts of human, messy research experiences in trials, but certainly not in randomized controlled trials.
Right.
But in practice, if there's an observation trial that's happening or some sort of thing that is very pragmatic, which allows in the real world, life continues to happen. Conditions progress, they ebb and they flow, and everything that people are living in is not a controlled environment, which is why having an RCT or randomized control trial be the gold standard of how evidence is evaluated for massage therapy or any applied discipline is dumb.
Yeah, it's just not a great match for how our work really happens. And what would we call that? We would call that poor external validity, right? Oh, look at me.
Excellent. And as the
external validity means what's happening in the intervention is similar to what happens in the real world.
Right. So it's those differences.
Oh, I'm so excited.
Efficacy and effectiveness. Efficacy is in your randomized controlled trials. Effectiveness is measured in real world situations and pragmatic situations. So it lets you know that treatments and therapies do work. You may not be able to draw a direct causation with it because of all the things that are not controlled for. But for applied disciplines such as those more pragmatic trials not only tell us a lot more about how we're seeing things in practice, but it's also more informative to our practice. The information that comes out of that is more informative for our practices, which I think is one of the really nice pieces that is highlighted in these cases as well, because in all of these, it identifies different ways that each of these clinicians were working with the person on their table to give them some control, to give them some agency, which is one of the pieces that really falls into this trauma-informed treatments, right? Say more about that, Ruth. I can see you wanting to.
Why, yes. So I think at the risk of making it sound like a bandwagon, because things can get a little gimmicky. Trauma-informed care, trauma-informed approaches to care in whatever setting. We could be talking about dentistry, we could be talking about visiting your GP, or we could be talking about getting a massage. a trauma-informed approach basically works to create an environment where someone who is anxious about being in your space can feel the least anxious possible, right? And I ended up looking into this. I am not an educator for trauma-informed care, and I would not ever want to be interpreted in that way. And there are some really, really excellent educators doing this work right now. And if we do show notes with this, I can give you a list because I happen to be up to speed on this. But when I have looked at the topic of trauma-informed care, and I've looked at some documents created for the medical community saying, here are some recommendations. It is such a match. It is such an obvious match. It's the kind of things we learn in the first week of massage school, right? That you make eye contact and that you don't be dinking around in your office while your client can't see you, and that you you get information from them about what they would like to do and not do, and you get informed consent. And it blows me away that this is something we had to say out loud to the medical community. So, there are lots of ways of talking about trauma-informed care and trauma-informed approaches. But I think if we lean hard into what makes people look forward to a massage, which is feeling like you're in a safe, clean room and that someone is giving you their full attention and really listening to you, to your words, but to your nonverbal signals too, and responding to what you want and need. Those are the baseline principles of trauma-informed care. So, we could say more about this and might before we're done today. But I was happy to see people acknowledging this. And in one of them, I think it was the woman with the very serious underlying diseases where she colored in the charts every day that she got a massage. She had a chart and crayons, and she got to color in where she wanted touch and where she didn't want touch and what parts of her body felt odd.
Yep.
And I thought, that's brilliant. That is absolutely brilliant.
So this is a measure that's called the Fitch Body Diagram Assessment Tool.
Do we know if that's for Pam Fitch?
You know what? I don't know. I imagine that it's cited.
Yeah, it must be cited. Yeah, said number 17.
Yep. Yes. Talking
Pamela Fitch.
Body, Listening Hands, A Guide to Professionalism, Communication, and Therapeutic Relationships.
I have that book. It's a fabulous book. And Pam Fitch is someone, if you ever get a chance to be in the same room with Pam Fitch, you should do that.
I don't know if I know Pam. I will have to reach out. I know.
You have she's in Canada and is not traveling to the United States at this point. But if you ever get the opportunity to work with Pam Fitch, you should do that. She's amazing.
Excellent. Well, one of my favorite things in any sort of research paper are the pictures, and these particular pictures are even colorful, which is always, truly fun. But it's great ways of conveying information. And from a measurement standpoint, they introduced. So this is the article with Melissa Clark, the massage therapist, and Beth Steinberg, that they introduced this a little bit later in the series, but started doing these pieces and showed us a couple of those diagrams that occurred because they, every time they came in before the treatment, they were able to do that because it gave information like where to get, like green was, yes, this is where I want to have touch. Red was the no, completely off limits. Yellow was like the cautionary, maybe.
Yeah, yellow was cautionary, and blue was this feels weird.
Yeah, I don't even know what
that was like for paresthesia, things like that. Yeah.
So with something like that, you could actually look visually and descriptively at how those pieces change, and they report on that. One of the other, since we're on this particular case, one of the other measurement tools that Clark and Steinberg used as well was the subjective units of distress scale, which is a 0 to 100 range scale with totally relaxed on one end at a 0 and as high anxiety as ever on the 100, and also allows them to give comments. So a real quick, easy assessment that they also did before, and we're watching those pieces progress over time. They have, in addition to their lovely charts with the colors, also gave some really great qualitative data from comments. And I want to highlight this because this treatment wasn't started and Melissa Clark, as the massage therapist, said, oh, this is going to be a case report. I'm going to do this, right? It was over time of seeing, and in fact may have even been completely retro, looking back in case notes.
I
But
think it's described as a retrospective report.
okay, so the treatment had already all occurred. And one of the things that I hear from massage therapists who feel intimidated by putting together a case report is, well, I don't know what kind of, I didn't give any assessments or anything like that to begin with, because I didn't know it was going to be a case report. But they have some of the quotes that just let them know that, yes, this was being well received. Yes, she was coming back. And that was the initial kind of data that they were gathering. And as they added tools in, you're able to do that in a case report. Bring things in the middle, or however it's occurring in practice. So they give a little table with some of those quotes. They, of course, show the pictures of that particular, the diagram piece. And these are actually a series of case reports that all of them have really great organization in some way, form, or fashion, using tables and figures to report on what was collected and then what the outcomes of those collected pieces were. One of them had a great timeline table and showed the progression of the experiences, and then once the treatment started, then started talking about when the treatments occurred. I think that was with the history of domestic abuse.
That was the Anna Hannes and Sarah Fogarty.
Yes. Yes, so this was domestic abuse.
Oh, and this is the one that was retrospective, which made me surprised about one of the assessments that they had gathered.
Okay.
Before we get into charts and graphs, which I know are your favorite.
Go ahead.
And not mine. One of the things that you and I were that the three of us were discussing before we got started today was, although all three of these case reports dealt with clients who were dealing with various forms and severities of PTSD, they all used really, really different measurement tools.
Yep.
For someone listening to this who's thinking, gosh, I have someone who might be a really great match, where do we go to look for appropriate and validated measuring tools? And by measuring tool, we're not talking about a goniometer. We're talking usually about some certain kinds of surveys or questionnaires.
Yep.
And we can't just make up our own. I want to really emphasize that you can't just make up your own questionnaire. This is that it doesn't work.
Well, you can. It's just not as valid and reliable.
It's not validated, and you may not be getting the information that you're really asking for. So better to go with something that's been tested for sensitivity.
Yes.
Where do we find those? Do you know?
There's lots of different places that one can look. Some of the tricky pieces here are what can be used for free, because some of these pieces are proprietary, unfortunately.
Right.
And then also some of them are really, really long. So one place to look is in the promise measures that NIH has done. And one of the reasons
great.
that I speak to that one is it was developed in response to so many of these validated tools being behind paywalls of some sort.
Right.
That make it really hard to use in practice. But there are some, including the one that the Hannes and Fogarty case report used, the GAD-7, which is the general anxiety tool, and it is open access. And one of the things that I'll go do is go into Google Scholar if I'm looking for measures. Go into Google Scholar, and then I'll type in like whatever it is that I'm looking for, like the condition, and then measures. And see
there you
what
go.
Pops up,
Google
right?
Scholar. How do we get to Google Scholar, Niki?
go to Google and type Google Scholar, and then you go to that
Or
search engine?
scholar.google.com.
Oh, I don't know. I always go to Google and just type in Google Scholar.
So Google Scholar, in case you didn't know, is a fabulous resource. It is a Google search that leaves out,
Non-peer reviewed.
yeah,
Well, actually, it
you
does.
get journal articles and things, but it leaves out advertisements and people who are promoting businesses.
Right.
And what you get to is mostly academic materials.
Yes. 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 Um, and also, one of the other great places to pick up data collection tools is reading case reports and
Right.
seeing what other people have used. So if you're digging into the literature at all, you can start seeing, if there's a condition that you're learning about, if it's available, use the same measures that have been used in other cases, because then you can
That's a
really couch your outcomes within the other outcomes that have been.
That's a great idea. And then we get some kind of conformity for how we are gathering data.
Yes,
And
yes,
that makes it easier to use in the future.
yep. I want to point out too, in this one that used the GAD, and so this was the Hannison Fogarty one with the history of domestic abuse. And by the way, this person was no longer in that but were not in that
Right.
situation. They were in a safe environment, felt comfortable with their family, and etc. But there was also a series of questions and symptoms that the practitioner used just in general, and had them do a check, what are you experiencing at this time for every one of the treatments. And so there's this lovely figure one that goes across all 6 of the treatments that happened in this case study,
Oh, yeah.
and does a little color for each one of those to let you know, like, what was being experienced, how often and when, and then just listed the other ones that they never indicated at any of the times,
Mhm.
such as choking, fear of losing control, trembling, shaking. Like, those were questions that they asked about, what they were experiencing, but they never indicated. She never indicated that she had that, so they were left off of the graph. But just a great conveying of information. I'm going to quickly just highlight the measures that were used in that the one that we haven't talked about as much.
Yeah.
And this is the one with the Indigenous female.
Mhm.
They used a tool called, well, first of all, they used sensory testing, because this is the one that they were also looking
It
at.
was so strange.
Yeah, so they were doing, right, the sensory testing and like,
So the 2-point pin test.
mm-hmm.
Yeah.
And then they
And
also used a dissociative experiences scale 2, which is a validated measure that asks particular questions, and is able to quantify one's experiences. And so this is I thought I had it written down what the scale range was, but it is, because it's a validated tool, it does have like thresholds.
mhm.
So she did start off in the severe category um, of that measure, and was able to reduce that down to not as severe, but had a over 50% improvement in her score. And this was one of the other things that was really interesting about this particular measure, is that there was the raw score, and then there was also an adjusted score that
Yeah, and I wrote in
continued.
my margin notes here, ask Niki about this.
It's a statistical piece that was accounting for some of the potential variations
Mhm.
and variance that shows up just generally. And so when it's a stricter, more uh, it's a more stricter and regimented way of doing the analysis
And
for
so what
accounting.
did that do to her effect size? Because it was huge.
Well, what the thing that they showed was, because the adjusted scores still was patterned right with the raw
Oh,
scores.
good. Okay.
Yeah, showed that it was still really strong and good,
All right. All right. Just checking
beneficial.
on that. I have to say, I think this was my favorite one and the one that I learned the most about because it really focused on that dissociative
Mm-hmm.
symptom of PTSD and how that can interfere with treatment and, any kind of success and in terms of sort of reintegration into the world.
Yeah. Lots of practice application. I want to encourage everybody to go to that September issue of IJTMB from 2025. That would be volume 3, if I'm not
Yes.
mistaken, in that year. Check out these case reports in addition to all the other articles as well, all focused on mental health. And with that, I see that you've got a little brain to share.
Well, because the title of the issue is Touching the Mind.
Yes, that's perfect.
Which is, in fact, the title of my mental and mood disorders continuing education class. So we came to it separately, but it's, so I have a little brain.
I love it. I think you've got a big brain, Ruth Werner, but whatever.
And Niki, will you just give everyone a reminder that IJTMB is accessible? It's open.
It is open access, which is so important, meaning there's no paywall to get that information. There's also no paywall for authors to.
And that is unusual.
Yes.
I want to just say that in the new publishing world, where there's more and more that is available through open access because of some changes in rules, the publications have passed on that expense item to submitting authors.
Right. And that is not the case. Because of the generous pieces that the Massage Therapy Foundation provide for IJTMB to exist, in addition to our partners,
RMT ABC.
Yes.
Registered Massage Therapist Association of British Columbia.
Yes.
Yes. And we are so grateful to our British Columbia friends.
Very much so. It's wonderful. Thank you guys so much. This was great.
Our pleasure. This was fun. Let's do it again soon.
Do you want to talk about what's coming up?
You know what? Very briefly. So I'm super excited that we've got a couple things. One is that there's another special issue that's coming out for IJTMB. It's going to be focused on pain. It will be coming out in 2027. And submissions are due to IJTMB by December 1. And also in line with this theme of our case reports today that we focused on, just a reminder that MassageNet, which is the practice-based research network that the Massage Therapy Foundation runs, is also looking at doing a case series study within the membership of MassageNet. And the focus of the case series study is going to be on emotional well-being.
Yes.
So, that's fantastic. So if you are not a member, if you're a practicing therapist and you have clients who are, among their challenges is emotional well-being, sign up. How much does it cost to be a member of MassageNet, Niki?
Not a thing.
Not a thing. Not a thing. And sign up to MassageNet. What will happen is, when they are ready to start taking in information, you'll be recruited to have input. And then what your wisdom, your learning gets to add to the general whole understanding of massage therapy and emotional well-being. It is absolutely critical, not just for the profession, but for the world. Right. Because, touch and well-being, they kind of go together.
They do.
I should say welcomed touch.
Yes.
Yes.
Thank you both so much for being here. This was just wonderful. Let's do it again. And I'm glad that we did a throwback episode to when you two have done this before. So thank you for your time, and we will look forward to the next conversation.
Indeed.
Thank you guys. What a treat.
Bye.
If you enjoyed this podcast, please consider donating to the Massage Therapy Foundation so that we can continue to bring you this and many other resources to increase your knowledge and improve your practice. Thank you.